Hello everyone, this is Cha Orhalo speaking on behalf of UP Med Class 94 webinar team. This is an initiative of the University of the Philippines Medical Alumni Society. The UP Med webinar series is held every Wednesday from 12 noon to 1 p.m. Manila time. It deals on important, current, and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health doctors, primary care physicians, family and community medicine physicians, and other health workers. Registration is free. This webinar runs on the UP Manila Livestream platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the Livestream page, please watch the Facebook Live video on our Facebook page. This session will run for an hour with 30 to 45 minutes allotted for a lecture, followed by a question and answer portion, which will be moderated by Dr. Vicente Perez Jr. To participate in the webinar, please use the Q&A box found on the Livestream page, and for Facebook Live participants, please type your questions in the comments box. Please use the comments box for questions and other webinar concerns. An evaluation link will be emailed to you after the webinar. Please answer it to get a copy of your certificate. We will now call on our moderator, Dr. Perez, who is an internist and endocrinologist practicing at the Perpetual Succor Hospital and is a member of the celebrating class of UPCM 1994. Dr. Perez.
Thank you, Charisse. Our time now is 12 noon, and I am speaking from the Research Institute of Perpetual Succor Hospital in Cebu City. Welcome to all our participants. Today's webinar is entitled Putting Heart into Diabetes Management, Cardiovascular Risk Reduction in Type 2 Diabetes. The objectives for today are: number one, to discuss the relevance of diabetes as a cardiovascular risk equivalent. Number two, to present the results of key cardiovascular outcome trials in diabetes. Number three, to discuss strategies for reducing risk for cardiovascular diseases in diabetes. Our speaker today, Dr. Marsha C. Tolentino, is a graduate of the UP College of Medicine, class of 1994. After graduation from medical school, Dr. Tolentino proceeded to the United States to do her postdoctoral training. She did her residency and internship in internal medicine at the Montefiore Medical Center, Bronx, New York, and then did her fellowship in endocrinology, diabetes, and metabolism at the Beth Israel Medical Center in New York. Dr. Tolentino is a diplomate of the American Board of Internal Medicine and is a diplomate of the American Board of Endocrinology, Diabetes, and Metabolism. She is a fellow of the American College of Endocrinology. After completing her training in the United States, she came back to the Philippines and soon became active in endocrinology. She is currently a member of the National Board of Directors of Diabetes Philippines and is a past president of the AACE Philippines chapter. Currently, she practices at Perpetual Succor Hospital and Cebu Doctors Hospital University, where she does both clinical work and research. Here at Perpetual Succor Hospital, Dr. Tolentino is the head of the Diabetes Center and the Research Institute at TSH. May we now call on Dr. Tolentino.
Thank you, Ali, for that kind introduction. Hello to everyone. We will be talking about cardiovascular risk reduction in diabetes. I have no significant disclosures for this webinar, and this is the outline of my talk. I will first discuss the relationship between diabetes and cardiovascular disease, then present the key results for the completed cardiovascular outcome trials to date, and lastly, discuss the applicability of these results to our day-to-day clinical practice. So diabetes is a global epidemic. There are over 400 million persons living with diabetes worldwide, and the number is only expected to increase. Locally, the prevalence is 6.3%, with almost 4 million Filipinos with diabetes. Half of these patients, or almost 2 million, remain undiagnosed. So I would like to remind everyone of the symptoms of diabetes. You have here weight loss, polyphagia, polydipsia, polyuria, non-healing wounds, blurring of vision, and numbness and tingling of your hands and feet. So going back, most Filipino diabetics will have type 2 diabetes and not type 1. And over a third of them will die before the age of 60. The most common cause of death being cardiovascular disease. So the most common cause of death is either MI, stroke, or sudden cardiac death. After an event, will have to live long-term with these complications and the expensive therapies these entail. Studies have shown that diabetics lose up to 6 years of their lives compared to those who are non-diabetic, and this goes up to 12 years if they have cardiovascular disease on top of the diabetes. Now, how common is cardiovascular disease in diabetes? Let's look at this study with over 100,000 people followed for 20 years with no underlying cardiovascular disease. So you see here that the risk for an MI or stroke is up to 5 times greater for those without diabetes. Even worrisome is that the risk for MI or stroke may predate the diagnosis of diabetes. So remember, macrovascular complications can occur even in the pre-diabetic stage. Through the years, we have been focusing on HbA1c and treating our patients to target whether we use the ADA 7% or the AACE stricter 6.5% cutoff. It was proven that lowering the HbA1c decreased microvascular complications, and it was assumed that lowering glycemia decreased the cardiovascular risk. However, looking at these early trials, there was no definitive and consistent proof that lowering the blood sugar prevented MI or cardiovascular death. In fact, in the Accord trial, the risk was even found to increase. Less well-defined was the cardiovascular safety of diabetes medications themselves. Early on, in the 70s, the UGDP already showed increased cardiovascular mortality with one of the first-generation sulfonylureas, tolbutamide. Granted, this was not a cardiovascular outcome trials, but nor was it a well-defined study, but the signal was there and the drug was actually discontinued. However, thereafter, diabetes drugs were still evaluated and accepted based on their glycemic lowering capabilities, and newer classes of drugs were introduced to treat diabetic patients. It was only over 3 decades later, in 2005, when the PPAR alpha and gamma agonist muraglitazar was found to increase cardiovascular mortality despite good phase 2, phase 3 efficacy studies in terms of decreasing glycemia. This was found by the FDA on their assessment for marketing, and the sponsor actually withdrew the drug from the market. After almost another 5 years, a meta-analysis questioned the safety of rosiglitazone, and soon after, the Accord trial showed increased mortality with intensively treated patients despite superior HbA1c reduction. These resulted in the restricted use of rosiglitazone in the US and its withdrawal in the European Union. More significantly, this led to the US FDA to issue guidelines whereby new diabetic drugs were required to prove cardiovascular safety prior to being marketed. The European agencies followed soon after. The result of this, the era of the cardiovascular outcome trials in diabetes. You see here a mushrooming of these trials, especially in the newer classes of drugs, specifically the DPP-4 inhibitors, the GLP-1 receptor agonists, and the SGLT2 inhibitors. Let's see what these cardiovascular outcome trials showed. Starting with the DPP-4 inhibitors, there are 4 trials to date: SAVOR-TIMI, EXAMINE, TICOS, and CARMELINA. So SAVOR looked at 16,000 diabetic patients, 79% of which had established cardiovascular disease, and they were treated with either saxagliptin or placebo on top of standard therapy. They looked at the composite endpoint of MACE, or your major adverse cardiovascular events, which includes non-fatal MI, non-fatal stroke, and cardiovascular death. So in terms of the primary outcome, saxagliptin was found to be non-inferior to placebo. In other words, it did not pose additional cardiovascular risk to patients as compared to currently available standard treatment. However, they found an unexpected increase for hospitalization for heart failure. A sub-analysis was able to identify that patients who were at risk were those with a previous history of heart failure, those with decreased creatinine clearance, and those with increased pro-BNP. The next trial, EXAMINE, looked at 5,000 diabetics who were post-ACS. So these were a higher risk population. They were randomized to either allogliptin or placebo over standard of care, and they were followed for 1.5 years. So this is a shorter follow-up because events already occurred much earlier, considering these patients already were diagnosed with an event. So the primary outcome, allogliptin was found to be non-inferior to placebo, but there was also a trend for an increased risk for hospitalization of heart failure, although this did not reach statistical significance. Then in 2015, TICOS results were reported looking at sitagliptin in 40,000 patients with cardiovascular disease. For the primary outcome, which was a 4-point MACE, so aside from non-fatal MI or non-fatal stroke or cardiovascular death, they included hospitalization for unstable angina as a primary endpoint. So the study found sitagliptin to be non-inferior to placebo with no increased risk for hospitalization for heart failure and a constant, marginally lower eGFR. Interestingly, the TICOS trial was initiated by the company to evaluate the cardiovascular safety of sitagliptin after it was already being marketed. This was one CVOT done not in response to the FDA mandate, but just to evaluate long-term safety. The last trial for DPP-4 inhibitors reported last year was CARMELINA, looking at linagliptin in 6,900 patients and at high risk for not just cardiovascular disease, but renal disease as well. After 2.2 years, linagliptin was found to be safe with no increase in heart failure risk. Linagliptin also had a similar renal safety profile compared to placebo in these high-risk kidney patients. The trial confirmed that the DPP-4 inhibitor, linagliptin, can be used with confidence in this patient population. So this is what we know so far for the dipeptidase 4 inhibitors, or gliptins as we call them. They are generally safe. They are non-inferior but not superior in terms of cardiovascular events, even in patients with high cardiovascular risk. They may be used across populations with different degree of cardiovascular risk, including those with recent acute coronary syndrome. In terms of risk for hospitalization for heart failure, The differences may be due to the different molecules, so it is recommended to assess patients for their heart failure risk and choose those agents who do not increase the risk for heart failure in these patients. Let's now look at the SGLT2 inhibitors, which work by preventing the kidneys from reabsorbing glucose back to the blood. So far, there are 3 trials which have been reported. These include EMPA-REG trial in 2015 looking at empagliflozin, then the CANVAS trial in 2017, and late last year, the DECLARE trial. EMPA-REG looked at 7,000 patients with cardiovascular disease treated with empagliflozin or placebo for 3.1 years. The primary outcome was found, empagliflozin was found to be superior compared to placebo with a 38% reduction in cardiovascular death, a 32% reduction in all-cause death, a 35% reduction in hospitalization for heart failure, and also a reduction in the renal outcomes. So the EMPA-REG outcomes trial was really the turning point in the CVOTs done for diabetes. Before this, drugs were found to be safe but not superior to previously available treatment. Going now to CANVAS or canagliflozin, the results presented here are the integrated results of CANVAS and CANVAS-R or renal trial. So 10,000 patients in total followed for 2.2 years. Canagliflozin was found to be superior to placebo in terms of MACE with a 38% reduction in hospitalization for heart failure and a 40% reduction in the renal outcomes. However, there were more toe amputations in the canagliflozin group. DECLARE evaluated 17,000 patients, so the largest trial of the 3, with only 40% with established cardiovascular disease. 60% were patients with a history of diabetes and either hypertension, dyslipidemia, or a history of smoking. So these are less high-risk individuals, and the study was assessing primary prevention in this patient population in addition to secondary prevention. For primary MACE, dapagliflozin was non-inferior to placebo, but for the composite efficacy endpoint of cardiovascular death and hospitalization for heart failure, dapagliflozin was found to be superior. There was also a decrease in renal outcomes for the DAPA-treated group. So for the 3 CVOTs for the SGLT2 inhibitors, we can conclude that these drugs have moderate benefits on atherosclerotic major adverse cardiovascular events that appear confined to patients with established disease. They have robust reductions in hospitalization for heart failure and progression in renal disease, regardless of their baseline status. These effects may be due both to hemodynamic and metabolic mechanisms of actions. The safety issues for these classes of drugs include genital tract infection, Fournier's gangrene, toe amputations, and euglycemic DKA. So looking at the GLP-1 receptor agonists, these are incretin mimetics, which increase your GLP-1 levels and result in the enhancement of glucose-dependent insulin secretion, slowed gastric emptying, and a reduction of your postprandial glucagon levels. So there have been 6 trials to date, and we will talk about each one very briefly. So ELIXA looked at lixisenatide for 2 years, and they found that it was non-inferior to placebo with no increase in hospitalization for heart failure. In this study, renal outcomes were not assessed. The LEADER trial looked at 9,340 patients with cardiovascular disease or risk factors, and they were treated with either liraglutide once daily or placebo, and they were followed for 3.8 years. So here, liraglutide was found to be superior to placebo, and there was a 22% decrease in cardiovascular death, a 15% decrease in all-cause death, no increase in hospitalization for heart failure, and a 22% decrease in renal outcomes. They also looked at semaglutide once weekly injection in the SUSTAIN-6 trial. This is still not available. 3,297 patients with cardiovascular disease were followed, and they were found actually to be, semaglutide was found to be superior in terms of primary outcome compared to placebo, with a 39% decrease in non-fatal stroke, a 35% decrease in revascularization, no increase in heart failure hospitalization, and a 36% decrease in renal outcomes. When they looked at exenatide extended release once weekly for 3 years, they showed that exenatide-treated patients were safe or non-inferior to placebo in terms of the primary outcome, with no increase in heart failure risk. Looking at albiglutide in the HARMONY trial, they looked at 9,400 patients with cardiovascular disease, and they were followed for 1.6 years. And again, albiglutide was found to be superior relative to placebo, and this was driven by a 25% decrease in the risk for non-fatal and fatal MI, with no increase in hospitalization for heart failure. The last study looked at dulaglutide once weekly, followed for about 5 years in 9,000 patients. It has been reported that the primary outcome achieved superiority, but the full results will still be reported later this year at the ADA. So in terms of the glucagon-like peptide 1 receptor agonists, they have been shown that treatment with these drugs resulted in significant relative risk reductions in MACE, cardiovascular, and all-cause mortality. These effects may be mediated via anti-atherogenic mechanisms that decrease cardiovascular risk over time, and the difference between trials may be attributed to the different populations enrolled. Also, the drugs had different potency and duration of actions, and the adherence rates to these medications may have played a factor, as some were injected daily versus some which were injected once weekly. So, we now have diabetes medications that can decrease cardiovascular death, decrease MI, decrease stroke, decrease all-cause mortality, decrease hospitalization for heart failure, as well as delay the progression of renal disease. These results have pushed the ADA and the EASD to come out with revised recommendations for the treatment of diabetes as of October last year. Here, where the first line is still lifestyle modification plus metformin, the cardiovascular status of the individual is a primary determinant of the second-line treatment to be used. If the HbA1c is not reached, then the patients have established atherosclerotic cardiovascular disease, or if they have heart failure or CKD, this dictates the next step for the algorithm. For patients with previous MI, stroke, peripheral arterial disease, or revascularization procedures, start with a GLP-1 receptor agonist with proven cardiovascular benefit, or an SGLT2 inhibitor if the eGFR is adequate. If still not controlled, add on the other agent that you did not use and go down the line with a DPP-4 inhibitor, basal insulin, a TZD, or even an SU. For patients where heart failure or chronic kidney disease predominates, an SGLT2 inhibitor is preferable as second line to metformin. If not tolerated or contraindicated, then use a GLP-1 receptor agonist with proven cardiovascular benefit. And then go down the line again if your HbA1c is not at target. Remember to avoid a TZD in the setting of heart failure patients, and if using a DPP-4 inhibitor, use an agent that does not increase heart failure risk. The American College of Cardiology also came up with their decision pathway on patients with type 2 diabetes and CVT. So if the patient has both type 2 diabetes and atherosclerotic cardiovascular disease, then address both concurrently, meaning lifestyle modification, add an antiplatelet, make sure you have good blood pressure and lipid control, and add on metformin as glucose-lowering therapy. You can also consider adding an SGLT2 inhibitor or a GLP-1 receptor agonist with demonstrated cardiovascular benefit if needed. And then initiate clinical patient discussion and choose the drug that you decide. So, in the era of cardiovascular outcome trials in diabetes, where do we go from here? Remember, the FDA has decided to continue the CVOT mandate for new oral hypoglycemic agents. Well, diabetes management is no longer just glucose-centric. You have to address the multiple risk factors using evidence-based approach. Reductions in cardiovascular death have actually extended the lives of our patients with diabetes. But while the focus tends to be on cardiovascular risk reduction, please do not forget to address the microvascular disease. That remains a critical issue related directly to the glycemic exposure over time. So keep the HbA1c in check to preserve vision, kidney function, minimize neuropathy, and amputation. And use an individualized approach. Keep your patient central in mind when deciding how to treat them, and always avoid hypoglycemia. So I hope I have fulfilled my objectives for this lecture, emphasizing the relationship between cardiovascular disease and diabetes-related morbidity and mortality, and showing novel therapies that can address both. Thank you very much.
Thank you very much for that very insightful lecture, Dr. Tolentino. We would like to say thank you to today's sponsor, Merck, Sharp and Dome, MSD Philippines. We are now open for questions. For live stream viewers, please type your questions in the Q&A box. For Facebook Live viewers, please type your questions in the comments box. Our first question. Can you comment on the current status of using HbA1c for diagnosis of diabetes?
So in the US, the ADA has actually advocated that an A1C of 6.5% be used to diagnose diabetes. In the Philippines, this has not been advocated unless your HbA1c or your laboratory that does the HbA1c is actually reliable. So because of the differences between the different labs, and in fact, we see the different cutoffs if you see the results from your patients, it has not been advocated as a tool for diagnosing diabetes. I think we still advocate either a fasting blood sugar or using the OGTT and confirming these results 2 times before you actually label the person diabetic. Now, if a patient already has symptoms and their random blood sugar is already elevated over 200, then that is enough to diagnose them with diabetes. Happy? Any comments on that?
I think the same thing. I think it's because of the difference in laboratory measurements here in the Philippines. We still use, as Dr. Tolentino said, our numbers primarily to diagnose diabetes, not the hemoglobin A1c.
Any more questions? Or maybe you can ask.
Maybe Dr. Tolentino, you could comment on the cost of these drugs. We're practicing here in the Philippines, and we have data available from the US and the European studies. In your practice, how do you reconcile the advantages, the benefits of these drugs, some of these expensive drugs, with the cost we have here in the Philippines.
Okay. So, yes, it's true that the newer drugs are prohibitive in terms of cost. What we can look at or see is that maybe the cost for acquisition is higher, meaning the drugs themselves are initially more expensive compared to what we regularly use, like either sulfonylurea, metformin, or even the TZDs and insulin. But in the long term, if these patients are not getting admitted for a heart attack, a stroke, or other complications like dialysis or amputations, then long term, then it's going to be more cost effective. Okay. Having said that, then if the patients really cannot afford these new drugs, then perhaps you can still consider treating them with the older drugs like the sulfonylureas or insulin, as long as you still treat the patient. What I do in clinic is that I explain to these patients the benefit of the more expensive drugs. They're not necessarily, the cheaper drugs are not necessarily less effective, but because of these other effects like cardiovascular risk reduction or reduction in renal outcomes or even less hospitalizations, then sometimes the patient is able to understand that this might actually be more beneficial in the long term. Okay. However, if they really cannot sustain being on these medications, then I give them alternative treatments, which are still all readily available. So if you look at the other part of the ADA EASD guidelines, that I do not anymore show the whole thing, it actually showed there that there is still some use for either insulin or the sulfonylureas for those patients who really need better glycemic control and are not privy to these newer drugs because of the cost.
Thank you.
Discussion.
I think Dr. Tolentino covered on contraindications of some of these drugs, but maybe we can just talk a little bit about maybe review special population of patients, renal patients, liver patients, which drugs to avoid, which drugs may be used first in special population of patients, renal failure, metformin.
Okay, so I think this was discussed in the previous webinar. Like metformin, there's a cutoff for those who cannot tolerate metformin, or if it's contraindicated because of their renal disease, then you can consider using the other medications. So, for example, in terms of classes of drugs, there are certain sulfonylureas, the second line sulfonylureas that are safe to use even in CKD 3-4 patients. The TZDs, you have to be a little careful because of the fluid retention and edema that you see that might be contraindicated in patients with renal failure. For the DPP-4 inhibitors, for most of the DPP-4 inhibitors, you may need to decrease the dose in your renal patients, except for linagliptin, where you can use one dose for all patients, even those with chronic kidney disease stage 5. So for the SGLT2 inhibitors, whereas it was found in most of these studies that they actually reduce the risk for progression of renal disease, some of them are actually not going to, because of their mechanism of action, they will not be beneficial, or they're not going to be as effective if you use it in these patients. So that's why there's a cutoff for the SGLT2 inhibitors. For the GLP-1 receptor agonist, same thing. Some drugs have been shown to be useful at a certain cutoff, but if it's below that cutoff, then you should avoid it. And then I think that's it for all. And then of course, insulin you can use for all renal patients. In terms of liver, I don't think there's any specific contraindication. Maybe unless it's really hepatic failure, then maybe you shouldn't use metformin. Even in sepsis patients, you shouldn't use metformin. Yeah, add something else.
I think that was a good review because these are the population of patients we encounter really almost every day. Are there any more questions? Somebody is asking about the reliability of hemoglobin A1C in diabetes.
So as I already mentioned, it's not actually, in terms of HbA1c, it just shows us the glucose control over time. So you have to remember that in certain populations, like for example, those with anemia, sickle cell anemia, those who've had a transfusion recently, or those who are severely anemic, as I mentioned, it does not reflect actually the HbA1c, the glycemic status of the patient. So you have to look at the hemoglobin of the patient, make sure that there are no other risk factors, any other things that can lower or increase your HbA1c. And you should still look at the FBS or the postprandial blood sugar if you're evaluating the treatment that you're giving to the patient. In terms of diagnosis, I think because of the differences in the different labs, we already mentioned that we don't really use it first line as a diagnostic tool, at least here in the Philippines.
I think the only thing that comes to mind is using the hemoglobin A1C to confirm the sugar logs of certain populations of patients. For some teenagers, for example, who may not want to check their sugars and come in with pristine sugars with very good sugar control, but really something is not making sense. I think this is a good example of the population of patients where the hemoglobin A1C, we need to be able to confirm the reliability of the sugars reported with the patient, and if we need to make adjustments.
Yeah, so we usually see that in clinic. The patient doesn't, maybe for 1 or 2 weeks before they see you in the clinic, they stop all the sugars and the goodies, and then they come in with a fasted blood sugar of 90, but their HbA1c is 8 or 9%. So yes, sometimes it gives us a better reflection of what the glucose control is over time, and it gives us a better idea of whether the patient is adhering to the medication that we're giving. What is experience with teneligliptin? So teneligliptin or gliptin is actually another DPP-4 inhibitor. But personally, I've had some patients started on it, but just very few. I haven't had any personal experience with this drug. I don't know if you have.
No.
It's not actually in the US. I think it's here in the Philippines, and if I'm not mistaken, in Japan as well. But it's just another DPP-4 inhibitor. So there are actually some drugs like DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists that are still not available in the Philippines. And some of them have undergone outcome studies. So obviously, if they're marketed in the US or in the European Union, then it's mandated that they come out with these SVOTs. But if not, if they're not going to be marketed in the US, then they seldom have, they do not need to have the CVOT trials. What's the question?
Somebody is asking regarding patients who have very elevated blood sugars, fasting blood sugars in the high 200s, but absence of postprandial hyperglycemia.
Absence of polyuria, polyphagia, and polydipsia. So yes. So not all patients are symptomatic. So unfortunately, we've had patients with really elevated blood sugar levels in the 200s, 300s, who have had this chronic hyperglycemia and actually feel well on these glycemic levels. So unfortunately, if they're not symptomatic, there's no weight loss, they're not weak, then sometimes when you lower their blood sugar levels, they actually feel less well. What we need to explain to these patients are that they have microvascular complications and macrovascular complications that are actually happening even if they're asymptomatic. So what I actually do is just start them on additional medications to lower their blood sugar levels, maybe not drastically, and have them actually monitor their blood sugar levels, because if their fasting blood sugars in the 200s, then maybe their postprandial blood sugars are almost 300s or higher. So they're not necessarily asymptomatic, and that is the reason why we still advocate either doing an FDS or an OGTT in patients who you find, for example, with glucosuria, but who don't have the symptoms of polyuria, polydipsia, or weight loss. So you still have to do some blood tests in these patients. Okay.
Before we move on to the next question, we'd like to acknowledge and greet our participants. At this point, we have 108 live stream participants, and we have 176 on Facebook Live. So thank you and welcome again to all our participants. I think the next question refers to allergic reactions with some of the newer medications, allergic reactions, and probably side effects of these newer medications.
Allergic reactions. So I'm not, maybe for the GLP-1 receptor agonist, then sometimes in the injection site, some patients may have allergic reactions or reactions to the drug. In terms of the DPP-4 inhibitors, I haven't really seen patients who have allergies to these medications. Maybe some of them have loss of appetite they're not too happy about, or if they don't really want to lose weight and they lose weight on some of these drugs, then they may not want to be on these drugs. For the SGLT2 inhibitors, as I mentioned, the safety issues are really genital tract infections, not too much the UTI. So we always emphasize hygiene in these patients to prevent genital tract infections. In terms of the DKA, so I haven't seen it in clinical practice, but it's been reported euglycemic DKA in the SGLT2 inhibitors. But I think that's really more common if the patient actually needs insulin and you don't start them on insulin. So I think for those patients who really need insulin, they need to be started on insulin.
Our next question is asking about targets of treatment. For newly diagnosed diabetes mellitus type 2 patients, what are the target fasting blood sugars and postprandial blood sugars?
Well, for newly diagnosed diabetic patients, especially if they're young, they don't have comorbidities, then our goal is actually to treat them to as normal as possible. So for fasting blood sugar, whereas the ADA advocates like a fasting blood sugar between 70 to 110, maybe for these patients, I would really try to bring it lower than 100 without causing hypoglycemic symptoms, of course. For postprandial, what I have my patients do is I have them monitor their fasting blood sugar, and I always tell them that if you're eating the right foods, you're not taking too many goodies, then maybe it shouldn't go up by 40. So my cutoff is actually less than 140. I don't know what you use.
Yeah, I think
for postprandial.
It boils down to the population of patients that we're treating. Risk for hypoglycemia, like Dr. Tolentino was mentioning. Our next question. In a patient on long-acting insulin alone with cardiovascular risk and CKD, what is are there oral drugs that can be used with insulin?
Okay, so for this patient population, then I think if you look at the algorithm that I showed, then maybe the SGLT2 inhibitor is actually preferred if the EGFR permits it. So you can add on actually the either epagliflozin, canagliflozin, or dapagliflozin on top of insulin for these patients. But since they've been on insulin already long term, then I would just make sure that they're not too symptomatic or their blood sugars are not really uncontrolled, because otherwise you have to be careful about DKA. So maybe control their sugars, add on an SGLT2 inhibitor. You can also add on a DPP4 inhibitor safely, or an SU if the blood sugars are really elevated. But to decrease cardiovascular risk, then SGLT2 inhibitors. Okay, I think I see some of the questions also here. Glycomark. I'm not too familiar about glycomark testing. Do you have any idea about
I've
that?
heard glycomark.
Okay.
I think somebody's asking regarding some patients diagnosed with diabetes and given metformin, but after about a month stopped metformin. And I'm not sure if the question is asking about maybe the possibility of stopping some drugs, discontinuing some drugs after the patient is diagnosed with type 2 diabetes.
So again, if you just base it on just the fasting blood sugar, then like we mentioned earlier, if the patient, for example, stops all the like simple sugars in their diet, they're able to exercise and lose weight. And on top of that, you started them on a drug, most probably metformin. Then maybe they can bring down their fasting blood sugar from even as high as 200 to less than 100 after a month. And I've seen it in a lot of my patients. What I ask them to do actually is to also check their postprandial blood sugar levels. Because sometimes the fasting blood sugar is 90, but postprandial, you see 200 still or 180. And then long term, again, eventually, if they actually come back after 3 months, their HbA1c might still be elevated. So I have no problems if patients who are newly diagnosed, started on medications, change their lifestyle, take their medications, achieve good blood sugar levels, and want to stop the medication. But I really advise them that if they stop the medication, just continue monitoring your blood sugar levels, because if it goes back up, then you either need to go back on your diet, because most patients just stop after a month or two, or go back to exercising, or if needed, you have to go back on your either insulin or metformin or any other medication. So it's more common than you think, where people actually started on drugs, decide to stop it on their own. Even some patients are actually advised because of the maybe effect on the kidney or the liver. But I always tell them that as long as you monitor your blood sugar levels and we monitor your kidney status and liver status, then it should not be a problem. Okay?
I think the next question tries to address the use of glucometers, home glucometers for blood sugar testing. Is it reliable?
Okay, so in terms of blood sugar monitoring, the glucometers actually, they're not 100% the same as getting a venous blood sample. So sometimes there's a difference of usually 10 at the most 15% compared to your venous sample.
Should not be more than about 40.
Yeah, it shouldn't be more than 40. Yeah. So, and it's usually lower than the actual venous sample. So, but the thing is, I advocate the use of the glucometers to monitor the blood sugar at home, because you can't have the patient going to the laboratory every day getting their fasting blood sugar, because that's like several cc's of blood. So eventually, if they use the 1 drop or less than a drop of blood, you get the blood sugar level in 3 to 5 seconds. And they can monitor, especially if they want to know, like, if I eat this, does my blood sugar go up? Then I tell them to just check their blood sugar at home. They don't need to go to the lab every day. Is that it?
I think we have time for one more question. What fasting blood sugar, probably what random sugar would denote the start of nerve damage?
Okay, so neuropathy, retinopathy, nephropathy, they've all been shown to increase as your HbA1c goes above 6-7%, which is why 6-7% has been found to be the cutoff level. So if you look at that, that's probably a blood sugar of what's 7%?
150.
150, maybe an average of more than 150. So actually, that's actually where microvascular complications start to occur. So since neuropathy is part of that, then that's probably where it is. So most patients, I think, if they have numbness, but their blood sugar level is like in the 120s, 130s, you probably need to make sure it's not from something else and not diabetic neuropathy. But if the blood sugars are elevated, maybe an average of 180, 200 or more, and they have bilateral tingling of their hands and feet, then it's probably because of the diabetes. You probably don't need to do EMG or NCV for these patients, and you need to advise them to control their blood sugar levels.
We have a question here. Is there still a strong recommendation for using aspirin routinely for cardiovascular risk reduction?
I think for secondary prevention, it's still advocated. Or if not, any antiplatelet therapy. For primary prevention, that has been where the debate is. There have been conflicting studies of whether or not to start all high-risk patients on aspirin. I think the debate goes to and fro. For me, if the patient's really high risk with not just diabetes, but also hypertension and dyslipidemia, then I will start my patient on an antiplatelet. But if the patient is younger, with just the diabetes, fairly well controlled, no other risk factors, then I give them the option and see if they can also tolerate it. What do you do in your practice?
So I think you're still going back to the risks and benefits
Yes.
on the patient. Yes, exactly. I guess if we have no other further questions, we'd like to thank Dr. Marsha Tolentino for that very engaging discussion. To summarize, we learned the key points in reducing the risk of cardiovascular disease in diabetes. We were also refreshed regarding the results of the key cardiovascular outcomes trials in diabetes mellitus. After this session, the link to the evaluation form will be emailed to the email address you entered the attendance form. Please answer it immediately to get a copy of your certificate a week after the webinar. Webinar recordings of our previous webinars are now available at the UP Manila official YouTube page. You may access the following webinars through the link flashed on your screen. Thank you once again for joining us. We would also like to thank our sponsor, MSD Philippines, for their support of this webinar. We hope to see you again in our upcoming webinar on March 6th, Wednesday, 12 noon to 1 o'clock Manila time with our speaker, Dr. Jean Antaral, entitled Stemming the Tide of Human Papillomavirus, sponsored by MSD Philippines. We will be webcasting again from Cebu City. Please invite your colleagues to join this continuing weekly CME webinar series. All webinar schedules and resources will be posted at the address given above. You may also email us at upmedwebinars2019@gmail.com for any inquiries. On behalf of UP College of Medicine Class 1994, our class, and the UP Medical Alumni Society, we also thank our collaborator units, UP College of Medicine, Postgraduate Institute of Medicine, the UP Manila Information Management Series, IMS, and AEIHN. This is Dr. Vicente Perez with Dr. Marsha Tolentino and the UP Web Medicine webinar team closing this session. We hope you have learned a lot from today's webinar. Please join us again on March 6th. Please also join the 2019 Aging and Longevity webinars every second and last Friday of the month. Thank you very much.